So hello everyone, welcome to my another video. So today's topic is ketamine. So ketamine is actually associated with dissociative anesthesia. It is an NMRDA receptor antagonist. Please keep this point in mind. It is a very important point. It is characterized by evidence on EEG, which ensures dissociation between thalamocortical and limbic systems. So it is characterized by the evidence on the EEG, which ensures dissociation between thalamocortical and the limbic systems. Hence, the anesthesia caused by the ketamine is termed as dissociative anesthesia because it ensures dissociation between the thalamocortical and the limbic systems on EEG. And intense analgesia is the salient feature of the ketamine. It produces intense analgesia. So whenever ketamine is used in total intravenous anesthesia, it itself can produce intense analgesia. So let's look into the mechanism of action of ketamine. So different isomers of ketamine reacts with different receptors. So let's look at the first point here. It reacts with NMDA receptors, N-methyl D-aspartate receptors, in a non-competitive antagonism action. Also it reacts with opioid receptors, MAO receptors and muscarinic receptors. And the last and the most important point, that it does not react with the GABA receptors, whereas the previous chemical called the thiopentyl sodium reacted with the GABA receptors. And in case of hypotension, we were unable to use the thiopentyl sodium because thiopentyl sodium itself causes hypotension. But here it is not so. Here the ketamine does not react with the GABA receptors, whereas the thiopentyl sodium does react with the GABA receptors. So have a note of it. So now let's have a look at the pharmacokinetics of the ketamine drug. So it is highly lipid soluble, means highly lyophilic in nature, and hence it is quick action within. It shows its quick action within 1 minute of intravenous dose and after just 5 minutes of intramuscular dose. So have a note of it that it is highly lipid soluble, hence it shows its quick action within 1 minute of IV dose and after just 3 to 5 minutes of IM dose, intramuscular dose. And it can readily cross the blood-brain barrier too because of its lyophilicity. Have a note of it. And let's look at the other points too. So it is not significantly bound to proteins, hence rapidly redistributed all over. So the next point is readily can cross the blood-brain barrier, as we looked into it earlier also. Being lyophilic or hydrophobic, it can easily cross the blood-brain barrier, and high hepatic clearance elimination ensures that its half-life is just 2 to 3 hours. So let's look at the metabolism of it. It is metabolized extensively by hepatic microsomal enzymes to form norketamine. Further, this norketamine is hydroxylated and conjugated to form water-soluble glucuronides, which can be further released out by the kidneys. So what happens, that it is metabolized by the hepatic microsomal enzymes to form norketamine, and after that it is hydroxylated and conjugated to form water-soluble glucuronides, which are then excreted out by the kidneys. So have a note of it. So let's look at its uses now. So first use is that it causes intense analgesia, and do note the dose at which it causes intense analgesias. At the dose of 0.2 to 0.5 milligram per kg body weight, it causes intense analgesia if given intravenously. Then it has limited use in the neuroaxial analgesia case. Then induction of anesthesia, the dose 1 to 2 mg per kg intravenously and 4 to 8 mg per kg intramuscular dose. If it is given at this dose specifically, then only it causes anesthesia. And the type of anesthesia in case of ketamine is also called as dissociative anesthesia, because we already looked at that point that on EEG it causes dissociation between the thalamocortical and the limbic systems. So hope it's clear. And now let's look at the other point, induction in case of hypotension in trauma patients as well, because in case of thiopentyl sodium we were unable to use it in case of hypotensive patients, because thiopentyl sodium itself caused hypotension, but it is not so in case of ketamine. So ketamine can be majorly used in case of trauma patients too, in case of hypotension means when the blood pressure is low in patients. So have a note of it. let's have a look at the systemic effects. So in CNS level, it causes increased cerebral blood flow, CVF, increased metabolic requirements, and increased ICT, intracranial tension. Also, it increases the amplitude of SCPs in the CNS level. Now, at the cardiovascular level, it increases blood pressure, it increases cardiac output, it increases the heart rate and the myocardial oxygen requirement. So have a note of it. So in respiratory system, no significant depression of ventilation is there. It acts as a bronchodilator, so it can be safely used in the COPD patients too. And hepatic and renal blood flow not altered significantly over here in respiratory system. Then allergic reactions are very rare, and volatile anesthetics prolong the duration of action in case of ketamine. So these are the points under the respiratory system of the systemic effects. Have a note of it. So now we need to know about the emergence delirium, the phenomena of emergence delirium. So what is it actually? So it is an acute confusion state during recovery from anesthesia. Means a state of confusion which is seen when the patient is being recovering after the process of anesthesia. So post-operative delirium is common with ketamine anesthesia, and the incidence percentage is about 5 to 30% of all cases induced with ketamine. So in 5 to 30% cases of patients treated with ketamine face emergence delirium after the anesthesia. So auditory, visual and confusional status progressing to delirium, cortical blindness, transient hallucinations, etc. So have a note of it. So now the mechanism of how emergence delirium occurs. So it is secondary to ketamine induced depression of inferior collicus and medial geniculate nucleus. So now the prevention, how it can be prevented. Inclusion of midazolam and diazepam in pre-medication decreases delirium, and exclusion of atropine in pre-medication also decreases incidence. And finally, the side effects of ketamine. So the short-term side effects include delirium, dizziness, diplopia, blurred vision, nausea, vomiting, etc. And some effects include hallucinations, psychomotor retardation, etc. So it's all about ketamine. I hope you enjoyed the video. So please share this video, like the video, and if you are new to my channel, please do subscribe and keep watching, keep learning. Thank you.